So hello everyone. I will be speaking about evidence and indication of spine SBRT in patients with oligometastatic disease. So hello everyone. My gratitude towards organizers for giving me this opportunity to present. I'll be briefly talking about evidence and indication of spine SBRT in patients who have oligometastatic disease. So spine, as we all know, is a common location for metastasis and is associated with significant morbidity. Commonly, conventionally fractionated RT for spine metastasis includes fractionations like 8 single fraction, 13-10, or 20-5. And the overall pain response from these conventionally fractionated EBRT is of the range of 60 to 70%, and complete pain relief has been reported in about 20% of the patients, while the tumor control with conventional EBRT is not well studied. With SBRT, one can deliver high biologically equivalent doses, which ultimately translates into better local control rate, better and longer pain relief. It is reported that up to 40% patients can have complete pain relief. There are also reports of improvement in the neurological status. When used in postoperative setting, the neurological status is maintained. And in oligometastasis, when SBRT spine is given, then it improves the progression-free survival and sometimes helps in delaying the change in the systemic treatment as well. This concept of oligometastasis was proposed by Hellman and Wishelbaum in 1995, which actually refers to limited metastatic disease or intermediary state, which we look at as an opportunity to extend survival of patients by adding local treatment. With advances in imaging like MRI, PET scan, or disease-specific PET scans like PSMA PET scans, now we have a greater ability to identify oligometastatic disease. At the same time, we also have advances in radiation techniques, which allows us to give ablative doses of radiation therapy. Definition of oligometastasis is still controversial, and ESTRO and ISTRO propose that based on the available evidence, it can be considered any patient who has up to 5 metastases with a controlled primary tumor being optional, but where all metastatic sites must be safely treatable, can be considered as an oligometastatic disease. This definition is purely based on imaging and number of metastases, and biology and genetics behind oligometastasis is still evolving. Now, oligometastasis does not represent a single disease. It actually represents a spectrum of disease, which can be synchronous oligometastasis or metachronous oligometastasis, oligoprogression, or oligopersistent disease, which further makes it difficult to identify the suitable patients, because within this spectrum, there can be variation in the prognosis of these patients. Now, there are a lot of rationales for considering local ablation or high doses of radiation therapy in oligometastatic state. The rationales are, one is that it is a potentially curable state. If you are able to ablate all the foci of disease, then about 20 to 30% patients can go into long-term remission. From the patterns of failure studies, we know that up to 2/3 of the patients, actually, when they progress on the sites of initial disease itself. And giving ablative doses can lead to some kind of tumor debulking, which might shift the tumor growth kinetics back and increase the sensitivity to systemic therapy. And local ablative radiation therapy is also known to induce immunomodulation, which can sometimes translate into abscopal effect also. So these are various rationales for using ablative doses in oligometastatic state. If you look at the evidence, the evidence which is acceptable in today's world comes from the SBRT data, which included patients with all sites, all primary cancers with oligometastasis, who were randomized into 2 arms, control arm, which received the standard of care. This arm was allowed conventionally fractionated EBRT also, 8 single fraction or 13-10 was what was used. And in the test arm, patients received SBRT to all sites of oligometastasis. Now, the results of this SBRT trial showed that the arm which received SBRT had almost doubling of the overall survival. Overall survival is a very hard endpoint, and it could be seen that in these patients, without much toxicity, the survival could be doubled by adding SBRT or ablative doses of radiation therapy to all sites of metastasis. If you look at the evidence which is specific to spine oligometastatic state, there is paucity of evidence there. But this is one interesting epidemiology study, which is actually a multi-centric prospective cohort study, including around 400 patients with spine metastasis who were treated with either surgery or radiation therapy. And in this study, they showed that patients who had oligometastasis, these patients lived longer. They had a better survival as compared to patients who had polymetastatic disease, irrespective of the type of treatment. And patients who had solitary metastasis, they had still better local control rate at 6 months and 12 months, which means that these are the group of patients who are likely to do well. But everything comes at a cost, and spine SBRT is certainly significantly more resource intensive for both patient as well as institutions. So it is critical to ascertain which patients are likely to benefit most from this intensive treatment. So I would say the first and the most important step will be a good MDT discussion, including all oncologists who are participating in the treatment of the patient. It is a good idea to start a spine MDT also, in your institution, so that you can discuss whether the surgery is required or radiation is required or plasties are required. Now, there are a number of schemes which are available in literature to identify overall patients who are likely to benefit with SBRT spine. Some of these are NOMS nomogram, which is proposed from MSKCC or International Spine Oncology Consortium report. Dr. Sareen has already, I think, covered this in his lecture, that you have to look at overall global performance status of the patient. If the patient's life expectancy is less than 2 months, a patient has poor performance status, he's unlikely to be a candidate for spine SBRT. But if the patient has a good performance status, minimal to moderate disease, which is controlled, or even if it is not controlled, there is an effective systemic therapy available, then one can consider suitably these patients for spine SBRT after going through more details about the patient. So as I said earlier, patient selection is key for SBRT. And I think if I have to select a patient, the first and the foremost thing which should be looked at is the patient's expected outcome. If a patient has a reasonably good performance status and his outcome is likely to be a survival of more than 3 to 6 months, then these are the patients who can be considered for SBRT. And there are various indices which are available, RPA or PRISM guidelines, prognostic index for spinal metastasis, which can be used to identify this subset of patients who are likely to have good prognosis. And these generally include a lot of factors like age, performance status, disease-free interval, etc. For example, in this RPA, which is specific for SBRT to spine, the time from the primary diagnosis is the most important bifurcating point. If the patients have a good disease-free interval, and if the patient has a good performance status, then these patients are likely to do much better as compared to patients who had a shorter disease-free interval, or patients who are above the age of 70 years, or patients who have poor performance status. So if your patient falls into group 1, then he or she is likely to benefit most with spine SBRT, while if the patient is in group 3, then these are patients who are likely to not do well and may be offered only conventional RT. Similarly, we have PRISM guideline also. One can put the patient into these various factors. For example, you can look at the performance status of the patient. Previously, surgery was done. If a patient has a solitary metastasis, then this probably will be a candidate who's likely to benefit with SBRT. So this is an interesting paper which was recently published from University of Canada. They looked at the prognostic factors associated with patients who are surviving for less than 3 months versus patients who are surviving for more than 3 years. So they looked at the extremes. So in surgical practice, or as per ASTRO guidelines, SBRT or surgery is generally considered for patients who have a prognosis or who have a survival of more than 3 months. So out of all their patients who were treated with spine SBRT, they identified prognostic factors which could help them identify patients who were surviving for less than 3 months or patients who were surviving for more than 3 years to identify the suitable patients. What stands out in their analysis is that the patients who have oligometastatic disease have a much improved survival as compared to polymetastatic disease. So probably this is the group which is likely to benefit with spine SBRT. Similarly, they also found that patients who had breast or prostate histology, their outcomes were much better, followed by lung cancers, followed by renal cell carcinoma, melanoma, thyroid, and others. So this is the group of patients who are likely to benefit, who are likely to be the candidate for spine SBRT. Now, radio-resistant histology, as we all know, they do much better with spine SBRT. So in oligometastatic disease, it becomes more of an indication to consider SBRT for this group of patients. In SBRT also, there are a couple of reports which say that patients who have metastasis coming from sarcoma or RCC, when given SBRT, they benefit more with single fraction SBRT as compared to multi-fraction SBRT for all the radio-resistant histologies. There are histologies which are not exactly radio-resistant, but they are special histologies where the molecular subtype is such that the effective systemic therapy is available and the patients are expected to have long-term survival. For example, ALK or EGFR mutated non-small cell lung cancer, or HER2/neu positive or hormone receptor positive breast cancers. Because these patients are expected to have long-term survival, these patients would also be candidates for SBRT. When some of these patients with spinal metastasis require surgery, then surgery is actually only to fix the unstable spine or decompress the high-grade epidural soft tissue component. It is not the definitive therapy, rather it is a neoadjuvant therapy. So all these patients should be treated with SBRT so that their local control rate is improved. For example, this picture shows a patient with a large metastasis from RCC underwent decompression. Now this is a post-operative scan. You can see that still there is a lot of disease. They could decompress or they could do only a separation surgery. So SBRT is essential in this situation. Another very strong indication for SBRT is the patients who require pre-radiation, because rapid dose fall off is a hallmark of SBRT by which one can suitably spare spinal cord. These are various studies which have used spine SBRT in the form of re-radiation and have shown great local control rate in the range of 70 to 80% with minimal toxicity. This is a retrospective study from coming from Stanford, which found that patients who had spine SBRT as a re-radiation, they had a local control rate of about 87% at 7 months, which is very good. And out of all these patients, also best outcomes were seen in patients who had interval of more than or equal to 12 months between two radiations, and where a single fraction equivalent dose of 15 gray was minimally used. Similarly, this is another paper which showed use of re-radiation spine SBRT in 43 patients who were previously treated with either conventional RT or spine SBRT. They used spine SBRT in the range of 1 to 5 fractions, and the local failure rate at 6 months were only 7%, so which is quite good. Another very important indication for spine SBRT would be patients who have bulky or complex spine metastasis. For example, when the metastasis has a lot of paraspinal soft tissue component or epidural soft tissue component, these are patients who are unlikely to benefit much with conventional EBRT. And it was shown in one of these papers from University of Virginia that when spine SBRT was used for these patients in 3 fractions, 24 grain 3 fractions, a lot of these patients, they benefited, and the local failure was seen only in 8% patients, and 76% patients had significant pain improvement as well as improvement in their neurological status. Another possible indication for patients with SBRT will be patients who have epidural disease. Ideally, these patients should have a decompression surgery, but at times when the decompression surgery is not possible for whatever reasons, then rather than doing conventional EBRT, these patients will benefit with SBRT, but it should be done with more caution. This is a study from Liu et al. 85 patients who were treated with epidural soft tissue component with spine SBRT. They found that mean epidural tumor reduction at 2 months was about 65%, and about 80% patients showed improvement in the neurological function also. And for all these reasons, spine SBRT has now found its place in the guidelines also, and especially in the oligometastatic situation, or especially if the patient requires re-radiation. RTOG 0613 got its first results published in Astro presented in ESTRO in 2019, which showed that there was no significant difference in proportion of patients with pain response or change in the pain score at 3 months. But I think further follow-up is required before we actually draw any conclusions. Similarly, this is another phase 2 study which looked at the pain response between SBRT versus conventional RT and showed that at 3 months as well as at 6 months, there was a significant improvement in the pain with spine SBRT. This was the long-awaited trial from University of Canada and Australia. The results have been published recently. Phase 2 study which compared 24 grain 2 fraction SBRT versus conventionally fractionated EBRT 20 grain 5 fraction and showed that there was a significant improvement in pain response at both 3 months as well as 6 months when SBRT was used. So I would like to conclude by saying that spine SBRT results in significant improvement in pain and durability of relief is also better. There are higher rates of disease control. There are higher rates of neurological improvement, but it merits careful patient selection, careful planning and execution of treatment. It is a resource-intensive treatment, so it is certainly not for all. And I would say that spine SBRT should be considered in patients with oligometastatic disease when they have good performance status, they have a long disease-free interval, there are limited metastases, when there are complex metastases with a lot of soft tissue or multiple vertebral involvement, or re-radiation setting, or radioresistant histologies, or radiosensitive histologies with good prognosis. So this is the group which is likely to benefit with SBRT. Thank you so much for your patient hearing.